Good evening. My name is Francesco Emma, and I'm speaking from my office in Rome. Before starting, let me remind you, as usual, that your microphones are turned off, but that during and after the webinar, you can send in your question through the application that is present on your screen, and I will ask your question at the end of the presentation. The webinar will last approximately 30 minutes. We will then have 15 minutes available for questions. So our speaker today is Dr. Olivier Lidove from Paris. He is the head of the Department of Internal Medicine and Rheumatology at the Hôpital Croix in Paris. He has received his medical degree from the University of Paris 8, where he completed his thesis on cardiac, neurological, and psychiatric manifestations of Fabry disease. He is a member of the scientific committee of the French Fabry Patients Association, of which he was the co-president between 2005 and 2016. Dr. Lidove has worked in the field of lysosomal storage diseases for over 20 years, including Fabry disease, Gaucher disease, acid sphingomyelinase deficiency. In his hospital, Dr. Lidove works within a reference center for lysosomal storage disease, and he oversees the management of more than 80 adult patients with Fabry disease. He has authored more than 150 original articles, of which more than 50 are on Fabry disease. As you may have guessed, his talk today is on Fabry disease, the new great imposter. Please, Dr. Lidove.
Thank you so much, Professor Alba, for your kind introduction. I want to thank the European Rare Kidney Disease Reference Network. Good morning, everyone. I would like to introduce Fabry disease as a new great imposter. And of course, I will be pleased to answer your question at the end of my talk. So first, I want to dedicate this presentation to Dr. Jean Hertz, who was the head of the department and unfortunately who died yesterday. My disclosures are here with travel grants and speaker honoraria from 3 firms in the field. So, because I work in French, I propose you a menu with an introduction, Fabry disease as a new great imposter, what was the care of patients in the last 20 years, with enzyme therapy and chaperone therapy, but not only this. And we will speak about some perspectives and a conclusion. So, as an introduction, I would like to say that in Fabry disease, such as other lysosomal storage disorder, the pathophysiology is in an intracellular burden of macromolecules who accumulate. You see in the right part of the slide that when you suffer from a lysosomal storage disorder, you accumulate substrates in your lysosomes. One particularity of Fabry disease is that Fabry is an X-linked disorder, and for a long time we only consider men as affected, but you will see that female can be also affected. 7 exons, and more than 900 different gene sequence variant mutations known to date. What is the definition of Fabry disease? It can be simple, but for a monogenic disease, but it's much more difficult than this. Why? Because if you consider the biochemical analysis, the risk is to miss about 40% of female patients. If you consider gene mutation analysis, you can conclude at a Fabry disease, but perhaps your patient is only affected by a polymorphism or a variant who is not pathological. So some colleagues propose when you doubt about the sequence variant to perform, for example, a kidney biopsy with an ultrastructural examination, and it can be useful for diagnosis, such as in the right part of the slide, you can see blue toluidine staining with vacuolization of podocytes and capsular cells and tubules as well. So the main question that we have in your on the practical ground in your daily practice is, what is the diagnosis? It's quite simple when you see a so huge number of angiokeratoma, but you can have several lesions around umbilicus, and in other patients only 2 or 3 lesions, so it's quite much more difficult in that case. What is the best therapy for our patients? For example, this 44 years old female patient has a first symptom as a brainstem stroke as a first symptom of Fabry disease. In the second part of my talk, I will try to share with you that Fabry disease can be seen as the new great imposter. Why? Because at an early stage of the disease, patient can suffer from pain in extremities. It's quite very difficult for the physician. Why? Because your clinical exam is normal. If you perform an electrophysiological exam, is usually normal because patients are only suffering small fiber neuropathy, and patient can also suffer from abdominal pain and hay fever intolerance. At a later stage, patient can suffer from pain, but one question to ask people is, do you have pain in extremities? And if the answer is no, you have to find to check this symptom in a retrospective analysis. And this female patient told us that she was suffering excruciating pain between 10 and 30, and she was diagnosed at 50. Other symptoms are proteinuria, kidney failure, hypertrophic cardiomyopathy, and TIA and strokes. As an example, you can see here a stroke in the left thalamus in a young man. At any stage of the disease, patient can have cornea verticillata, better seen with a slit lamp examination, but the patient usually does not have any symptom and loss of vision. Of course, you have to check for amiodarone and anti-paludéan therapies, but if your patient doesn't take any medics, probably the first hypothesis is Fabry disease. Angiokeratoma, we have seen this, and a family history of Fabry disease is also a key point to evoke the diagnosis. And because of late onset symptoms on stroke, kidney involvement, and heart involvement that can be seen as the main causes of death, life expectancy is reduced in male with 50 years of life expectancy at, kidney disease, Fabry disease can be seen as a podocyte problem, but you can see here that you have also an ischemic nephropathy with this in this arteria, a reduction of the lumen and a vacuolization of the endothelial cell with 2 nuclei here. If we look at what were the specialties, we refer patients in internal medicine department in France. In that study, we found that the patient come from GP, pedigree analysis, self-referral, Dr. Google sometimes, internist, nephrologist, neurologist, pediatrician, dermatological, and so on. So great imposter, a lot of different specialties can make the diagnosis of Fabry disease. Fabry disease is not only a storage disorder, no spleen and liver enlargement in Fabry disease usually, but here you have a cluster analysis with 87% of the variance in 2 axes. And you see that if the diagnosis is made after 50 years of age, and if the patient has stroke, hypertrophic cardiomyopathy, kidney involvement, and hearing loss, all these symptoms are together. It's a clue for saying that Fabry disease is a vascular disease. Another argue is that there is a huge prevalence of renal phenomenon and nail fold capillaroscopic abnormalities in Fabry disease. Nathalie Triclin is in blue. Why? Because she was at that moment the president of the Patient Association, APMF. We performed this study with the French Patient Association. So a lot of vascular anomalies. One paper is in press with very severe vascular and full-blown Fabry disease involvement with vascular lesion in the pulps of the fingers of 3 male patients, only 2 here, with a very huge number of telangiectasia or angiokeratoma, only seen in very severe men affected. So the first question I would want to ask you at that moment is, what is the gold standard for the diagnosis of Fabry disease in male patients? So I let you vote, and we will see the answer with the voting system. So we can consider clinical phenotype, alpha-gal activity in leukocytes, lyso-Gb3, and gene mutation analysis of GLA, the gene affected in Fabry disease. So I don't know if we can have the results of the vote.
Actually, I can see them, Dr. Lidove, and 53% of people said alpha-galactosidase A in leukocytes and 32% gene mutation analysis. And then we have a 9% for the lyso-Gb3 in plasma and 6% for the clinical phenotype.
Okay, so all of you are right. The good answer was alpha-gal A activity in leukocytes, but it's true that gene mutation analysis is also important for the pedigree analysis, and lyso-Gb3 can be seen as a tool also, and clinical phenotype also is a key point to think about Fabry disease. So I don't know if we can go through to the next slide.
Tanya, can you help us with this?
Olivier, please go into your PowerPoint presentation again, and then just continue with moving forward the slides.
Okay, it's okay.
Okay.
So the second question I will ask you now is quite the same question, but for female patients. What is the gold standard for the diagnosis of Fabry disease in female? Clinical phenotype, alpha-gal A in leukocytes, lyso-Gb3 in plasma or in urine, or GLA gene mutation analysis. I'll let you vote, and we will answer the question afterwards.
And so maybe if you don't see the results, I'll tell them Again, so here we have a 70% of answers for mutation analysis, 25% for the alpha galactosidase A leukocytes, and 6% on the clinical phenotype.
Thank you so much. So the good answer was GLA gene mutation analysis. If you perform alpha-gal A in leukocyte, unfortunately, you will miss about 40% of female patients. So if we consider now women that can be seen now, must see now, not only as carriers, but they are sometimes severely affected. For example, if you consider the frequency of Fabry patients on dialysis, about 12% of all the Fabry patients on dialysis are female, and you have the same results in both parts of the sea. So, what is the explanation of 40% of females with normal alpha-gal A activity? Because of lionization, Marie Lyon has the Nobel Prize more than 50 years ago. She describes the inactivation of one X chromosome in each cell, and you have seen here tubular cells with mosaicism, with some cells with vacuolated cells. X, the normal X is inactivated, and in that cell, the pathologic X chromosome is inactivated. So you have a lionization. What is the usefulness of the deacylated form of GB3, also called lyso-GB3? And think, in my opinion, it's only a tool for diagnosis. If you consider all the patients affected, normal, classical male on the left part, classical female here, cardiac variant in male, and here cardiac variant in female, you see that only few female patients with a prominent cardiac form has a normal lyso-GB3, and all controls are below the threshold. So it means that if you have a normal lyso-GB3 level, it's an argue against Fabry disease. And I fully agree with Dr. Talbot from Melbourne Hospital in Australia that there is no evidence that lyso-GB3 can inform on clinical events to date. What is the care of patients with Fabry disease in France, in Europe? We have first to say that in France and in Spain, we have a lot of different centers with few patients, and in UK and Germany, we have few centers with a majority of the patients who are treated. So the organization of the care is different between the different countries. We have a reference network in France for the free next year with our network. We have also for patients an emergency healthcare card, very useful in case of emergency, because in the emergency department, usually the physicians do not know a lot of things about very rare disorders such as Fabry disease. 20 years of work for Fabry patients. You have here in the left part of my thesis, very old one, only male and no treatment. And 20 years later, Wladimir Mauhin, we performed this slide kit with him, and more than 100 people coming from everywhere in France, female, males, and treatment available. At the beginning, we only use the symptomatic therapy, and we have to control all the risk factors. And for example, it's very important for patients to stop tobacco. This patient has stopped tobacco about 1 month before the photograph was performed. Cardiac device implantation is also frequent in Fabry disease. In a recent paper in UK, about 10% of all Fabry patients have a PM or DIA. And you see here that the area under the curve, the main part is no diagnosis, the gray area. And you see that the majority of our patients in our department are very late diagnosed, and in yellow the diagnosis is made, in blue they are treated. So much more than PM and DIA, the diagnosis odyssey is illustrated here. For example, in a very old female patient, 76-year-old, you see that there is a complete AV block, and of course she needed in an emergency a PM. So the third question I would like to ask you is, one of your patients, male or female, is diagnosed with Fabry disease, and these patients suffer from a nephrotic syndrome with low albumin level below 30 and a high daily proteinuria. The answer is yes or no. Is nephrotic syndrome usual in Fabry disease?
And so the answer is 2/3, 67% says no, and 1/3, 33% yes.
Yes. Thank you so much for this feedback. So a majority of you are right. It means that nephrotic syndrome is very unusual in Fabry disease. And if you have a patient with Fabry disease who have nephrotic syndrome, I think kidney biopsy is mandatory. As an example, you can find lupus erythematosus, IgA nephropathy, and in that case, of course, do not miss that some Fabry patients have some parapyelic cysts, so it's important before to perform the kidney biopsy. And if you perform the kidney biopsy, as that case in a 55-year-old female patient diagnosed at 21, we found at a pathological examination of kidney biopsy at trichrome staining showing mesangial expansion and vacuolated podocytes, and in panel B and C at a congruent staining you can show glomerular and arterial deposits. So perhaps Fabry can be seen as an auto-inflammatory or at least inflammatory disorder. If your patient have edema in the lower limbs, it's not cardiac insufficiency, it's not nephrotic syndrome. Usually it's lymphedema, which is a primary complication of Fabry disease with 16% of male patients and 6% of female patients affected. So now we will speak about therapies we have to treat Fabry patients. I will speak about enzyme therapy. I fully agree with Tondel team from Norway that early diagnosis is crucial before to associate symptomatic and enzyme replacement therapies to improve school attendance and to improve pain, and of course to make prevention of later complications. If we consider enzymatic therapy, you have agalsidase alpha and beta. I will go fast, but in all with these two enzyme, you have bad results, mainly with patients with at baseline proteinuria and a low glomerular filtration rate. And it's true for both agalsidase alpha and agalsidase beta. And if you perform an infusion not every other week, but every week with agalsidase alpha in the left part of the slide, you can see that unfortunately you cannot improve the decline of kidney function. So what is the best treatment for these patients? Another illustration regarding kidney involvement is that if you consider the zero, you have no modification of your kidney function. The more you go to the left, the more you deteriorate your kidney function. And it's the black bars are historic cohorts, and the 6 upper bars are with agalsidase alpha for the 2 first one and agalsidase beta for the 4 others. And you see that the results are really different with patients below 1 gram by a day and patients with upper than 1 gram by a day, reflecting glomerulosclerosis. Sometimes with enzyme therapy, patient can have hypersensitivity reaction. And to date, no proof of improvement of life expectancy is so we have to consider early therapy to avoid glomerulosclerosis, dialysis, and auriculoventricular blocks. This patient is infused every other week in the department and was heart and kidney transplant 13 years in 2006. So now let's consider a new therapy, chaperone therapy, which is available for 3 years. You can see here that chaperone therapy is an immunosugar who do not need mannose phosphate receptor to go into the cell. How does it work? It means that you have a misfold mutation and there is a quality control, and your enzyme do not go to the lysosome. And you have a defective activity in lysosome. What is the aim of the chaperone is to rescue the folding of the protein and to improve glycosylation and trafficking and to increase the residual activity in lysosome. So I will go very fast for the results of the chaperone. First, there are two different studies, one against placebo, who was published in the New England Journal of Medicine 3 years ago with a randomization 1:1. Another one was a switch study with a randomization 1.5 to 1, comparing migalastat after enzyme therapy compared to continuation of enzyme therapy. And what are the results? The co-primary endpoint were kidney function. If you only consider kidney, we have regarding interstitial capillary substrate deposits. You can see that with the placebo, the red, you have an increase of the lyso of the GL3 in kidney, and after switching to migalastat, it goes down. And you have the mirror with migalastat first and the continuation of migalastat at month 12. There is a stabilization of kidney function. I will go fast here. You have a global stabilization of migalastat after 30 months, an extension study. And it was concluded as an abstract as a stabilization of renal function, but we have to keep in mind that below 2.7 differs from the natural history of decline of kidney function in a patient, a sibling not affected by Fabry disease, below 0.7 to below 1 by a year. And quite differences between male and females. Regarding heart, it's interesting to see that in left ventricular mass index, you have ERT here, and patients switch from migalastat, and in 31 patients at month 18, you have a decline of mass index, and it's a promising results with some results after extension at month 48, but do not miss that only 18% were analyzed here. I will go fast with surrogate markers. The plasma lyso-Gb3 mimics the EL3 in the kidney. And the proof of concept is if you concentrate to the right part of the slide, you can see that 4 patients in the switch study were considered amenable, but in fact, with a second version of the test were not available. 2 of them were switched to migalastat, and you see that the lyso-Gb3 goes up in these 2 patients. It's emphasized that it's a very precise medication, and you have to know that if your patient is available or not before to use chaperone therapy. The safety is quite good with 2 main adverse events. It means nasopharyngitis and headache, and you have the same results in red, so I will go fast. We described recently 2 patients who were treated first with enzyme therapy with bad result for him and bad tolerance from the other. And with a switch to migalastat, we have demonstrated that both patients have an increase in intracellular enzyme activity. So it's promising results with N215S mutation cardiac variant. What are the perspectives for our patients? So I must say that Fabry disease is not only a storage disorder, because no spleen and liver enlargement usually in Fabry disease, and a vascular involvement with vacuolization of endothelial cells. You can consider that the two representations I will want to share with you is that more than ischemia, you have also a profibrotic disease. We developed in France a patient need questionnaire regarding shared decision-making process. And during 1 year, we had a first list of items with patients, a second list, and the last version of your PNQ, 26 items. And this I will go fast, but these results you will be able to see the slides. You will see what are the, if Fabry disease was an animal. Some example, it's the voice of the patients, so it's important to share it with you. And a vital role of patient association at each step of the development of this tool, and how patients live and feel with about Fabry disease. You will read this. I go fast. This final version of the PNQ will be published soon in Orphan Journal, so you will be able to look at this, and this tool will help us to make a phase 4 study regarding observational prospective multicenter study to assess prospectively in real life patient benefits and patient satisfaction regarding their treatment. So as a conclusion, I will want to tell you that when I begin 20 years later, patients mostly were affected with full-blown multi-organ Fabry disease, and now the new cases of Fabry disease we diagnose are much more late onset cardiac variant Fabry disease with a majority of involvement in the heart. So the aim of the physician is to know if there is an extra cardiac phenotype, and we need an interdisciplinary team for our Fabry patients. One patient means one family. You have an example here. So I want to tell that for male patients, you have first to think about deficient alpha-gal activity in leukocytes, and in female patients, you have to think first about gene mutation analysis to avoid 40% of misdiagnosis. So as a conclusion, early ERT is clinically efficient, but it needs early diagnosis. Is not enough. We need nephroprotective measures and vascular protective therapies. And chaperone molecules is only available for about 30% of our patients, and long-term results are needed. I think it's important for you as a clinician to know that about 1/4 of classic patients are amenable for chaperone, and 68% of cardiac variants are amenable. It was performed with Wladimir Mauhin in one of his theses. The perspectives are perhaps in the next future substrate reduction therapies, gene therapy, or combination therapy, such as used in Pompe disease with chaperone and enzyme therapy. So I want to acknowledge patients and families, patient association, the reference center, and all co-workers in France and all Europe, and collaborators. And I would like to thank also Tanja Wlodkowski from Heidelberg for her help. Thank you so much for this. And if you have some question, it will be an honor for me to try to ask you. Thank you so much.
Well, thank you very, very much, Dr. Lidove, for this very clear presentation. And so Now you can send in your questions, and I will then ask them to Dr. Lidove. So right now, we still don't have we don't have questions. So let me ask you first: in a patient where that has a mutation that can theoretically respond to chaperone therapy, how do you proceed? Do you first try enzyme replacement therapy? Do you go now? Would you tend to go straight to the chaperone therapy? What is your attitude?
I think it depends. One key point is the preference of the patients. I try to give all the results I have to date regarding more than 50 years of experience with both enzyme therapies and about 3 years of experience with few patients treated with chaperone therapy. The first step is to know if the patient is amenable or not. And it's very tricky, because if you consider 112 position in the GLA gene, some mutations are amenable and others in the same are not. So it's very important. It's a precise therapy and individual therapy. I think, to ask your question, first, some of our patients were already treated with enzyme and they know that they are available, and they ask us, what do you think about chaperone therapy? I think it depends. One of my patients worked in another European country, and for him, it was really good for him to have chaperone therapy. It was really easier for him to be treated with chaperone therapy. But I think it's also important to tell people that for a naive patient, never treated, what we know about both therapies. And it's also important to share with you that chaperone therapy need to be in the intake of treatment is every other day, without any meal 2 hours after a lunch, for example. So it's and connected therapy is also important to improve the observance of even if it's an oral therapy. I think it's quite difficult to take every other day one pill.
Okay, and then now Dr. Guillaume Pintos Morel just anticipated my next question, which is, what do you think about the possibility of combining therapy in patients with a good response to enzyme replacement therapy? So to combine the two.
There is no experience to date and no published. Good evening, Guillaume. There is no proof to date about the possibility of associating both therapies. It was never done. It's possible to evoke this possibility, but we have to keep in mind that the chaperone therapy acts as a potential inhibitor of enzyme. So it means that perhaps we will need to infuse more enzyme if you associate chaperone therapy and enzyme. So for example, if you give 2 more time enzyme on therapy, the cost of the therapy will be very expensive, but it's not impossible to associate both enzymes, but it was never done and never published in my experience.
Okay, so Dr. Maria Weispis, I hope I pronounced well your name, ask you what you suggest to monitor female children that were identified by family screening, especially to detect important organs involvement like kidney involvement. So what is your suggestion when you have a female patient that you know is mutated, and how do you monitor her?
It's my nightmare. Why? Because I don't want to miss one female patient who is at risk of stroke, of kidney insufficiency, of AV block. But it's very difficult to find what is the risk of an individual female patient to develop severe involvement. We haven't got any surrogate marker or biomarker to know if the patient is at risk of strokes or cardiac problem. For the kidney, we can monitor kidney function, daily proteinuria of the protein creatinine ratio. It's less problem for patients in their daily life. But even if we perform if there is a red flag regarding kidney involvement, I think it's important to consider beginning therapy. For the heart, I think it's important to perform at least every year an electrocardiogram, echocardiographic examination, and perhaps 24 hours alter rhythm, heart rhythm, and perhaps longer with reveal or other systems. But it's quite very difficult to know if a female patient affected with 2 angiokeratoma and cornea veticillata, is she at risk of severe involvement? It's very difficult to answer.
You're clearly right, and this is a very challenging situation. So Dr. Christy Thomas is asking this question. I have a patient with onset of gastrointestinal symptoms at age 2, pancytopenia at age 3, and nephrotic syndrome at age 6 years with a renal biopsy showing Fabry disease. His evaluation revealed low alpha galactosidase level and a pathogenic variant in the GLA gene. How is his prognosis with enzyme replacement therapy? And he has an asymptomatic female sibling. What will be the management of the sibling?
I think the first part of the answer, considering the proband, I think this patient is severely affected, and I think it's crucial to think about initiation of therapy, specific therapy, even if the authorization, European authorization, means upper than 7 years for enzyme therapy and upper than 16 years for chaperone therapy. But there are some, even if we are outside the health authorization, I think early therapy is crucial, mainly for these very severely affected patients. So I will speak about a reference center to validate the early initiation, even if it's outside the health authorization, but it's quite tricky. Regarding the sibling, I think the sibling is, I hope, less severely affected. Only a survey, regular monitoring, and if there is a red flag, perhaps also to consider early therapy with a combination of specific therapy and symptomatic therapies.
Okay, and so far she's asymptomatic. So the other question comes again from Dr. Guillaume Pintos Morel. The question is, are you in favor of newborn screening for Fabry disease?
There are pros and cons. I'm not a specialist of this, but I think, of course, the one aim of my talk was to tell early diagnosis is crucial. So, of course, if we consider that early diagnosis can be made by this way, I think it's a useful tool. But on the other hand, ethics considerations are also to be kept in mind. For example, if you consider the study published by Spada and co-workers in 2004, they found 1 below 3100 as the frequency of Fabry disease in Italy. But if you consider all the mutations found, only 1 on the 12 patients found in their work will be severely affected very later. But the 11 were variants or polymorphism. So it means that ethical consideration has to be in balance between the usefulness for patient and the the difficulty to tell parents your child is affected by a gene mutation, but we don't know well if she or he will be affected in the next. So all has to be kept in mind before to validate this tool, in my opinion.
And I agree with you, and I think this is a very it's a very big question nowadays in newborn screening. So I have a last question for you. I mean, we know that we now have very large mutation databases.
Yes.
Are there any databases on clinical response to treatment according to mutations? Is there a collection of cases where, according to the mutation, then you know the probability of response? And I'm thinking mostly on chaperone therapies.
For the chaperone, we have a Migalasta amenability table. It's open in the web, so we can, for every patient on an individual basis, we can share this and to know if our patient is amenable or not for the chaperone therapy. And all patients are amenable for enzyme therapy, of course. But there is no table regarding effectiveness of both therapies, three available therapies regarding individual mutations. So it depends mainly on the age the diagnosis is made, because if you begin at 30 for a very severely affected male, probably there is a point of no return, and perhaps your patient will deteriorate the kidney. But if you can improve the slope of the decline of kidney function and avoid several years on dialysis, before dialysis, it's crucial, and I think it's very important to think about this. But the point of no return is perhaps 10 years, perhaps 20 years, I don't know exactly, but it's probably earlier than previously known.
Well, again, Dr. Lidove, thank you so much for this very enlightening and clear presentation. I think we learned a lot. And thank you all for listening. I'm not sure there will be another ERKNet webinar this year. Tanya, if you're listening, and if I'm mistaken, please pop in and just let us know. Otherwise, we will send you an email announcing the new webinars. We are right now in this day, we are planning the new schedule for next year, and we will let you know as soon as possible. Well, again, thank you all for listening, and until the next webinar, thank you very much.
Thank you very much.
Bye.